Hello, my name is Lily R.B. Suyellen. I'm a team member of Connections Official, a company that specializes in genealogical research services. Today, we will review a study that examines Haplogroup JT as a possible risk factor for poor clinical outcomes in type 2 diabetes. Diabetes is a chronic metabolic disorder that affects how the body converts food into energy. It is characterized by the inability of the body to either secrete enough insulin or to use the insulin it secretes as efficiently as it should. Also, since insulin is a catabolic hormone, its decreased availability affects the metabolism of carbohydrates, lipids, and proteins. Often, decreased insulin levels and or impaired cells' response to insulin result in an increased concentration of glucose levels in the blood, leading to varied complications. Among those complications, there are cerebrovascular disease, cardiovascular disease, diabetic nephropathy, and peripheral vascular disease, to name a few. If untreated, diabetes may lead to stupor, coma, and death. Strikingly, diabetes is the 7th leading cause of mortality in the United States. Unsurprisingly, some medical experts have described diabetes as the epidemic of the century. And by looking at the epidemiological data, we may understand why. Think about this. Almost 100 million people, or roughly 40% of the adult population in the United States, have prediabetes. And about 8 in every 10 of them do not know they have it. Also, about 37 million people have diabetes, and about 2 in 10 of them do not know they have it. Type 2 diabetes accounts for the majority of the cases, that is, 90 to 95% of all diabetic cases. The American Diabetes Association, ADA, has set specific criteria for the diagnosis of this disorder. Typically, 3 different lab tests are used in the diagnosis of diabetes: glycated hemoglobin A1C, abbreviated A1C, fasting plasma glucose, or FPG, and oral glucose tolerance test, or OGTT. Each test provides different pieces of information that can guide a medical health professional in establishing a diagnosis. For example, A1C provides information about how efficiently blood glucose levels have been maintained on average over the past 3 months. FPG offers a glimpse into how well glucose levels have been maintained in the absence of dietary glucose. If after a period of fasting for at least 8 hours, glucose levels remain high, a person may have diabetes or may be at risk of developing diabetes, especially if a trend is observed over time. And OGTT measures how well the body processes glucose. As you can see on this chart, a person who is consistently above the upper limit of normal in these measures has diabetes. However, people who consistently test slightly above the upper limit of normal without reaching criteria for diabetes are considered pre-diabetic. And pre-diabetes is a significant risk factor for diabetes. In addition to prediabetes, other risk factors include family history, like having a parent or a sibling with type 2 diabetes, an unhealthy diet characterized by hypercaloric foods or foods high in carbohydrates, obesity, being 45 years of age or older, having high blood pressure, having high cholesterol and triglyceride levels, having a sedentary lifestyle, for example, exercising less than 3 times per week, as well as ethnicity. Some of these risk factors, as you can see, are modifiable, and patients have certain level of control over them. For example, patients can modify their diet, lifestyle, amount of exercise, etc. However, there are risk factors that we cannot modify at will, such as family history, age, or ethnicity. Thus, a question Diaz-Morales and colleagues formulated was whether haplogroup affiliation in mitochondrial DNA had any impact on the clinical outcome of diabetic patients like age and ethnicity do. So why mitochondrial haplogroups? Well, mitochondrial dysfunction has been found to be involved in the pathophysiology of type 2 diabetes, and it affects both insulin secretion and insulin resistance. Variations in mtDNA may affect mitochondrial function and lead to the development of diabetes. For example, an mtDNA mutation at nucleotide 3243A has been described to cause maternally inherited diabetes and deafness. Another variant, mtDNA 16189T, has been associated with an enhanced risk of type 2 diabetes in Asian and European populations. So Diaz-Morales and colleagues posed the following research question. Is mtDNA haplogroup JT related to impaired glycemic control in type 2 diabetes? And to answer this question, they investigated the differences in metabolic parameters and renal dysfunction markers across different mitochondrial haplogroups. The objective of their study was to determine if haplogroup affiliation was associated with the risk of developing diabetic complications in type 2 diabetes. The study included 456 people from Spain, 303 patients with type 2 diabetes, and 153 healthy controls. Mitochondrial haplogroups HV, GT, and U were defined by the mitochondrial DNA polymorphisms 7028C, 14766T, 4216T, and 12308A. Just to give you an idea, these haplogroups accounted for roughly 90% of the Spanish population. Samples revealing other haplogroups with low frequencies among the population, that is, those not classified as HB, GT, or U, were grouped all together and referred to as others. For each genotype analysis, positive and negative controls from previously characterized mtDNA were used to ensure an adequate control. Here you can see a clear representation of the distribution of patients and healthy controls participating in the study. First, you see the 456 subjects. About 2/3 of them were the patients with type 2 diabetes, and about 1/3 of them were the healthy controls. All of them had corresponding affiliations to groups H, HB, GT, U, and others. Now, the clinical and biochemical outcomes that were measured included age, body mass index, waist to hip ratio, blood pressure, C-reactive protein, total cholesterol, triglyceride levels, fasting glucose levels, A1C, insulin, insulin resistance, creatinine in serum and in urine, albumin concentration in urine, and estimated GFR. Let's take a look at the first set of measures on this table. On the first row, you can see the two study groups. On the left, marked in yellow, the healthy controls, and on the right, marked in green, the patients with type 2 diabetes. First, the healthy controls were stratified according to the mitochondrial haplogroup, whether it was HV, GT, U, and others, based on their haplogroup affiliation as represented by each column. On the leftmost column in gray, you can see there are the study measures, including BMI, waist to hip ratio, systolic and diastolic blood pressure, and different cholesterol test results. The healthy controls were compared on each measure across groups, and as you can see, the p-values on the right show that there were no statistically significant differences on any measure across groups, regardless of haplogroup affiliation. All the healthy volunteers were equally healthy, so to speak. Likewise, when we look at the patients with type 2 diabetes, they were stratified according to their mitochondrial haplogroups. And when diabetic patients were compared on all the clinical outcomes listed here, there was no statistically significant difference across diabetic patients in different haplogroups. So all of them were equally ill, so to speak, at baseline in this study. And this is just to ensure that certain haplogroups do not come in to the study with certain disease biases. Now, when healthy subjects were compared to diabetic patients, there were statistically significant differences across all clinical measures, which is as expected, of course. Now, let's take a look at measures of glucose levels as well as kidney function. Here we can see the graphs showing the parameters related to glycemic control and insulin resistance. As expected, glucose levels and A1C between control subjects and diabetic patients remain statistically significantly different after adjustment for age, sex, and BMI. Also, as expected, the results for insulin levels showed statistically significant differences between the control group versus the patients with type 2 diabetes across all the different haplogroups. What was remarkable in this study was that diabetic patients within the JT haplogroup show significantly higher levels of fasting glucose and A1C than diabetic patients belonging to other haplogroups. These differences remain statistically significant even after adjusting for the duration of diabetes. Another important finding was that type 2 diabetic patients in the JT haplogroup showed a worse renal function than patients belonging to HB, U, and others haplogroups. These manifested as significantly higher levels of serum creatinine and lower estimated GFR. Differences between the JT group and all the other haplogroups in creatinine levels and eGFR did not change in the diabetic population after adjusting by duration of diabetes. That means they remain statistically significantly higher in patients in the JT haplogroup. Control subjects, as expected, did not reveal statistically significant differences in kidney function according to haplogroups, obviously because they are all healthy and their kidney function is normal. In diabetic patients, additionally, urinary albumin to creatinine ratio was slightly higher in the JT group than in those belonging to the other haplogroups. However, this difference did not reach statistical significance. So, what conclusions can we reach from this study? According to the researchers, the association between type 2 diabetes and haplogroups has been elusive, as the research literature is obscured by inconsistent results regarding the effects of haplogroup affiliation on type 2 diabetes. In this study, type 2 diabetic patients belonging to the JT haplogroup showed higher levels of FPG and A1C when compared to patients in the other haplogroups, that is haplogroup H, U, and others. Likewise, kidney function was worse in patients in the JT haplogroup, as evidenced by higher creatinine levels and lower eGFR than patients in other haplogroups. These results were consistent with data reported by Crispin et al., which showed higher levels of insulin resistance in diabetic patients affiliated with the JT haplogroup. So this is an independent study that showed similar results. In summary, findings from this study indicate that the JT haplogroup, particularly mutation 4216T, might be associated with poorer glycemic control, leading to the development of diabetic nephropathy in patients with type 2 diabetes. What are some of the limitations of the study? The study had limitations regarding statistical power. The researchers did not perform a sample size estimation due to the lack of studies assessing the role of HB, GT, and U haplogroups on metabolic control and renal function. Although statistical significance was reached in some measures, larger research studies are needed to confirm these results. If confirmed, haplogroup screening in newly diagnosed T2D patients might help predict disease progression and select an effective treatment to ameliorate the risk of vascular complications. Thank you for listening to this presentation. If you need additional information, please visit us at www.connectionsofficial.com. And don't forget to subscribe to this channel. Thank you.